Ginny,
can,
Ginny, just want to make sure, that we also acknowledge the fact that Dr. Schmelzer was your Golisano Institute mentor,
oh,
helping
absolutely.
you with this project too. Uh,
Thanks, Diane.
we're grateful.
Oh, absolutely. I'm
Yeah.
gonna make sure you can see my screen. Can everyone see my
Yep.
screen?
Mhm.
So right on top,
There
I
it
have,
is.
there it is. Because, one of the things I wanted to say was I really pushed back a lot because I didn't have the time and Suzanne kept saying, but nobody's done this and you've got to do it. So when she kept putting it in that perspective, I just kind of trudged and pushed through, and thankfully I got it done. And now we're working on part two, and we are doing like a qualitative study, and we're doing part two. So
Terrific.
that's good things. And there's hopefully a part three and four, but we'll get to that in a moment because this, I'm trying to condense the talk, and I know everyone's busy, but I'm a nurse anesthetist. I give anesthesia, and I'm also program director at Florida Gulf Coast University. And this is my vacation week, so I came to New Jersey for the week, and I actually worked in my old job in the OR the last 2 days, and it was like, it wasn't even work because I saw my friends and it was great. But regardless, I wanted to do this. It was an honor to actually be asked. And, I don't want to be too redundant. Obviously, you're the experts, but there's some highlights that might kind of intersect with what you're doing and what I've noted over the last few years. All right, let's see if I can get this going here. Okay. So with my objectives, part of the project was to identify knowledge gaps, particularly with nurse anesthesiologist training and, with the, student registered nurse anesthetists with, IDD patient care. And then the big thing was you think you know what you know, but you really don't know. So you're assessing self-perceived competence, particularly about nurse anesthesiologists practicing and giving anesthesia with patients with IDD, and then looking at current education models for preparing clinicians, across the board, but really we focused on nurse anesthesia programs, and then tried to develop some recommendation to change curriculum, and then promote some evidence-based practices to improve anesthesia outcomes for patients with IDD. So that's why there's so many parts to it that we have to kind of break them into different sections and then talk about them separately. And that's what I'm working on next. So the big issue is, again, we healthcare workers think we know a lot, and we think we know what we should be doing, especially when you have a patient with intellectual and developmental disability, and we think we know more than we do, and we really don't. And there's a lot of implicit biases, and I don't think I need to tell you that. And it's just history keeps getting repeated. So one of the big problems are that providers do lack confidence when trying to make decisions regarding healthcare for patients with IDD. And there is no clear, specific guidance for training and education. So these are some of the things that we discovered with the study that we had for nurse anesthesia. And, we're trying to chip away at that and change things. So there is a national challenge, and historically it's always been a challenge. It's getting better, but it's slow. And it always shocks me to think about, more than 25% of Americans have disabilities, and 1 in 4 Americans lives with a disability, some form of a disability. And then a quarter of our population also lacks regular health care. So if they don't have health care, they don't have a healthcare provider, and therefore they skip routine checkups. So then preventative care kind of goes out the window. And now you're dealing with more acute care issues instead of trying to manage and be preventative. Some of the barriers related to that is 1 in 4 individuals with disabilities, they can't meet healthcare needs due to cost constraints. So not only don't they have the access to care, or they don't have the access to maybe insurance, but they are the poorest of poor. And they can't get hired, they don't have anything to help them. So people just figure, well, they don't need healthcare anyway. So they're just kind of, I feel, for lack of a better word, it's kind of discarded population. Thanks to Judy Heumann, she was very significant in the civil rights movement, and she and her peers in 1977 did that 504 sit-in, and that really catapulted things towards, 1991 Americans with Disabilities Act coming into law. And, over the years, there's been some updates, but in 2024, there's been updated regulations, and it specifically states about prohibiting discrimination, accessible medical equipment, and digital accessibility. And again, it kind of blows my mind that we have to say that in a regulation, and it hasn't already been done prior to this. So it's moving in the correct direction. However, we're still kind of behind the trend of what we need to be doing. There's a lot of negative assumptions when healthcare providers were surveyed, and persons with disabilities were surveyed, and they feel that they're excluded from healthcare, that, even they feel out of place, and they're always assumed to have a poor quality of life. So if you're assumed to have a poor quality of life, what do you need to care for anyway? And if we're going to give you care, we're really not going to give you the best care. We're just going to give you this, bare minimum. And there's a lot of misconceptions about patients with disabilities. They don't perceive pain or feel pain, so therefore they don't even really need anesthesia. And then on the other end of the spectrum, we don't, as anesthesia providers or healthcare providers, we don't even want to deal with this population of people. So we'll just over sedate them or over anesthetize them just to keep them quiet. So there's kind of this black and white thought process when it comes to care, especially in anesthesia. And that, these persons with IDD, they don't have normal sexual feelings. They don't feel certain ways. They're not perceived to have these certain feelings, and we seem to forget that they're human when we bring them to the operating room or into the pre-op area. And, all of us, when we go to the pre-op area, we're kind of like stripped down. We have very thin, hospital gown on, thin sheet, and we all feel very vulnerable, and we're scared and nervous. They feel that too. And, they feel embarrassed as well, the same ways we feel embarrassed. And I think that people tend to forget that and discard that. And we have to realize, like, there's a human right there. And, yesterday, as a matter of fact, one of my first cases was a young woman, 28, and she's with her mom. And I could see, that she had some kind of disability. Intellectually, she could articulate, but physically there looked to be some type of disability, but I couldn't put my finger on it. And she was there for an orthopedic procedure, and I tried to show her as much kindness and kind of bridge the gap with her mom. And her mom's first language was not English. And then the surgeon came over, who I know very well, I've known him for 30 years. It was, like I said, it was fantastic working with him again. And his son has a severe disability. Severe disability. My daughter has a disability, but not as severe as his son. And we've always bonded over that over the years. And as soon as he walked up to her, he was talking to her, and he said, she's been misdiagnosed, and she's never been diagnosed with, she's got cerebral palsy. No one's ever diagnosed her. And when I was looking at her limbs and doing an assessment, looking at her IV, there was kind of a spasticity there and a limpness to her limbs a little bit. And like she didn't have full control. And then it clicked that he was 100% right. So here's this girl, 28, I asked her, how did she injure herself? Oh, I fell. And I'm thinking, oh my, how did you fall? And here, she probably fell, you know, she had probably weakness, been undiagnosed, didn't get the right PT. So then now this guy, the surgeon is like, she needs to get intensive PT. We're going to do this and this and this. And so then I had to explain to the mother and the pre-op nurse, like I said, you know, please don't let her dismiss this. She needs this care. She's still young enough. And that's what I mean about just this discarded population, you know. And if it wasn't for a physician that has to deal with taking care of his bedridden son every day and still does an excellent job taking care of his son, and it takes other people with you know, empathy to realize that this girl needs extra help. And she was kept saying to me, you know, I spasm, I shake. I go, it's okay. It's okay. I will remember everything you're telling me. I will tell the nurses in post-op, don't worry, but you know, I've got you. And you could tell, like, she doesn't normally get listened to, and it's very sad. So that's what it comes to, like, communication and trust. You know, when people with disability are surveyed, there's a big disconnect between healthcare and these patients in this population. They don't trust us at all, and it's really sad because, you know, nursing is the most trusted profession, right? Year after year, but yet this population of people, we're missing the mark, and that's very, very problematic. So we have to learn that there might be some communication difficulties and there might be a lack of trust. That's why I already go in with the assumption that they don't trust me. So I'm going to prove myself even more and repeat things and reassure them and demonstrate through my actions that, you know, I'm definitely your advocate. So I think that's, you know, some of the things that we really didn't talk about a lot in school. I've never been trained like this. It was kind of trial and error. And then now with going with Golisano and learning so much, you know, these are some of the things that I always had in me, but now I've emphasized this in my care. So what does it have to do with anesthesia? You know, because anesthesia doesn't get talked about a lot either. And it's really because there's a lot of surgeries that happen because there's surgical statistics and IDD patients. So there's 313 million surgeries globally. And there's 50 million surgeries in the United States, and they're kind of estimating 15 million are ambulatory surgeries. However, I believe that number is probably becoming much higher because the majority of the surgeries that we do now are ambulatory. And when you have surgery in a patient with IDD, they have a higher risk of post-op complication. And that circles back around to the type of care that they're getting pre. So if they're not going to see a doctor or they don't have a healthcare provider or they're not treated preventatively, we're dealing with patients that have more acute issues. So then these are the patients that are going to develop respiratory issues post-operatively. Maybe I won't be able to extubate them. They could develop a stroke because they're poorly mismanaged with their hypertension. If they have hypertension that's undiagnosed, they have poor wound healing because maybe someone didn't explain to them or got a case manager involved to make sure that this person, you know, is taken care of afterwards, so we don't have readmittance into the hospital due to infection or poor healing. And ultimately they could get very septic and end up in the ICU, have septicemia, and then acute renal failure. So these are some of the things that are highlighted as part of risk factors for this group of individuals. Now, the thing is, patients with IDD, not only do they have maybe one surgery a year, but they have 1+ surgery. So again, this girl yesterday, you know, she fell, she got taken care of in a foreign country. The surgeon's looking at like what was done before. She had limited range of motion. He was very worried. We anesthetized her. She had better range of motion. He felt more relieved. He did what he needed to do. And then he also said, you know, she's got some plates and screws in here that are just malaligned. No wonder the poor lady can't do this, this, and this. I'm going to bring her back. I want this to heal first. And then I'm going to bring her back and readjust and try to optimize her. And I thought it was wonderful that he's thinking futuristic for this girl, but what that means is a second surgery for her. So we have to start thinking like that as well, is that these patients are, part of our wheelhouse, right? So they're frequent flyers. They come in, and if you have somebody with spina bifida or have multiple back surgeries, back in and out, or somebody with cerebral palsy, and you're giving Botox injections and doing range of motion under anesthesia. I've done lots of these surgeries specifically for pediatric and young adults. So it is true that these patients are, frequent flyers of the operating room. Now with anesthesia, there's key issues that are related to patients specifically with IDD, and we perceive anesthesia that these patients are very unwilling to cooperate. They tend to be aggressive, and it's like, well, if you understood why, maybe you wouldn't label it like that. And so this is where this big misconception, lack of knowledge amongst anesthesia providers. And then there's a problem with communication with these patients. Some can't articulate at all. Some can articulate minimally. And if they can articulate, maybe they're not articulating clearly. Maybe they don't have the caregiver at the bedside that they need, that really, really knows them. Maybe that's the caregiver from the group home that clocked in this morning and doesn't know the patient at all. I've run into this multiple times. It's very, very sad. And so there's really tends to be no consistency in care. And that's where then when we pre-op the patient and we're assessing the patient, it's really hard to get a clear picture when the patient next to them, who's their, significant other for that moment, and guardian, and they don't have a clear picture of their health history, then how am I to get a clear picture of the health history, right? It's very difficult. And the one thing that, anesthesia providers don't appreciate is that 90% of patients with, people with IDD have experienced physical, sexual, and emotional trauma. That's 90%. And it's very, very scary. That's a big number. And so no wonder when they come into the OR, we've stripped them down. They've become completely vulnerable. They don't have an advocate at the bedside. They have a very unfamiliar setting, and they may have past trauma that they're thinking about. So when we come at them, we're touching them without permission. We're doing these things to them. We're trying to start an IV. No wonder they're fighting back. So we kind of have to change that point of view of how we're looking at individuals with intellectual and developmental disability. It shouldn't be that they're a pain in the neck, they're uncooperative. It's they have a past. So we need to appreciate that when we're approaching these individuals. So the physical, sexual abuse and trauma, this usually begins early on in childhood, and there's a lot of sexual and physical abuse that occurs. And I know when I read that Golem Girl book, she talked about in her book how she was actually molested in the hospital as a young girl, and she didn't know if it was real or a dream, but she was drugged, and she was definitely physically and sexually abused. And so her story, unfortunately, is not unique. And out of that 90%, 49% have had 10 or more abusive experiences in a lifetime. That's astounding. So when you have that, and then you have someone that with IDD is trying to explain that this has happened, we tend not to believe them. They're not credible. They don't count, right? They're not real. They're not human. So now, who are they going to talk to? Nobody believes them. So to me, it's very, very sad. Every time I think about this, I get a little teary-eyed. And it's like, we have to stop this cycle, because when you have someone in this situation, maybe keep all their clothes on, maybe talk to them in a separate room and introduce them slowly into the environment where, give them some control about changing, their outfit into this gown, and, things like that, to give that patient more control, so then they're not maybe as combative and they understand things a little bit more. And, there was a Facebook post probably a year ago in my CRNA, SRNA, Facebook group, and somebody put on there, very derogatory about how they have this obese patient that's got, autism and whatever, right? Very derogatory post. And, I see some people writing like, well, you should try this, you should try that. And then I see some people making jokes, and typically I wouldn't respond. I don't want to get into a social media fight because it doesn't matter to me, right? But this one really mattered to me. And so I just said, basically, very succinctly, is maybe instead of making, this a joke, you need to look at this from a different perspective, and that this person needs care and they're not, part of a joke. Maybe that's your insecurity coming out, and we should be looking at this population of people with more care. And the way I said it, I was very succinct in what I said. And, I probably read it over and looked at it very carefully before I posted it, because, once you post it, that's it. And I had people agreeing with me, and it shut down the conversation. So I was really proud of myself, because I felt that as part of being from Gideon, right, that was part of my moral duty to speak up on behalf of this population of people, and on behalf of Gideon, because I think the problem is we think we know, but we don't know. So when these patients come to us and they have this luggage of past trauma, that we can actually diagnose these people, right? That they have a legitimate diagnosis. And because when someone has trauma-related disorder, they have recurring memories. So then if, you would come in the OR, come in the pre-op area, it might provoke these memories. And then it might provoke like irritable behavior, startled reflexes, increased sympathetic nervous stimulation, nervous system stimulation activity, fight or flight, thrashing around, pulling the IV, confusion, aggression. So this fits that non-cooperative patient. So instead of us looking at it that way, we should be looking at it this way. And I think that's going to help us all appreciate that patient a lot better. And then our own insecurities will go away, because I think some people they don't really know what they're doing, so they tend to lash out at the patient. So with the study that we kind of put together, we did a nationwide survey, and we got 227 responses, which I thought was really good. And it was from CRNAs and student registered nurse anesthetists or registered resident nurse anesthetists. And they were from diverse clinical settings, from hospitals all the way through office settings. And experience levels ranged from 1 year to 25 years plus and up. And it was a cross-sectional study with a 12-item questionnaire. So we created a questionnaire, we got the data, we did a review of literature, and we looked at anesthesia-related, clinical challenges and things like that. And there really is very sparse. There's really nothing in the literature. And there's nothing in the literature about specifically talking about anesthesia-related training. So we wanted to try to develop like a curriculum analysis and look at something that we could do specific for patients with IDD for anesthesia, and then look at best practices, what other concentrations are doing. And I think, at least with the dentist dental society, they're at least acknowledging patients. They call them patients with special needs, but at least that's part of their accreditations standards. So that I think we as anesthesia need to be doing that, a little better. So the participant demographics were usually 75% CRNAs, 25% student registered nurse anesthetists or resident nurse anesthesia. And the gender were 67% female. Experience was evenly distributed amongst the years of practice, and then age, majority 35 years and younger. So when we asked the questions about being prepared, 57% of the nurse anesthesia students and CRNAs felt that they were unprepared to take care of patients with IDD through the perioperative period, meaning with assessment from pre all the way through post and discharge. And 82% admitted that there were no courses, anything specifically rated, specifically towards patients with IDD in their anesthesia program. So nothing related to that. And 90% said that they needed training and they recognize the importance of improving care. So that was very, very good that we acknowledge that. So with this, self-perceived confidence, the thing that's interesting about this is that 24% of the respondents felt highly confident. And out of those 24%, they had more experience. So that it kind of makes sense. The longer you've been doing something, the more prepared you think you are. But the problem with this is that it's trial by error. So, this didn't work. Let me try to do this. So the longer you've been doing something, and then you figure out maybe what works. But what we're doing is we're kind of experimenting on patients when we shouldn't be. We should really have, specifically, outline things to train nurse anesthesia providers on what to do. So we're not trial by error. And some of the things that we were, well, me personally, that I was doing, I definitely wouldn't do that now. And what I mean by that is, you've got a patient that's combative, and me not appreciating the statistic of 90%, with abuse, I wouldn't come at that patient the way I've come at the patient before. I've completely changed that dynamic. And in the past, we thought we were doing a favor by kind of gently restraining them while giving them a shot. And then the shot was to sedate them. So then we could start the IV. But I feel like that's backward and barbaric. Now that I say that out loud and think about it, after everything that I've read and gone through over the last several years with Gideon, I find that very barbaric. So we need to understand, the population that's being impacted. So it's about 65 million, but 1 in 6 children, and 40% of those individuals require procedures and anesthesia because, again, if like, for instance, my daughter has intellectual and developmental disability, and I was going to bring her in for a gynecological appointment, and the OB-GYN surgeon and I were talking, doctor and I were talking, and she's like, do you think she'll stay still for the exam? And I said, I don't know. I don't think she will. And so we discussed options. Like, we can give her nitrous. I said, I'm safe with that. I feel safe with that. We'll make sure she doesn't eat the night before, the morning of. I'll come with her. And then when we got there, she said, you know what, there's really no need to examine her physically. And we don't have to do this. And we'll do this instead of this. And I was very comforted in the fact that we had a plan, but I was her advocate. And, what about the patients who don't have advocates, right? And then the training gap. So there is inadequate education on patient with IDD. So we need to close that gap. And I think, bringing this to attention is going to help us. So trying to integrate some form of IDD specific information into nurse anesthesia programs. Me personally, I'm a program director, and I create scenarios, and then I have the students write up treatment plans, and then we discuss those treatment plans. And a lot of times I will bring up photos of patients that have different physical attributes that are linked with, maybe a developmental disability or intellectual disability. And then we discuss how we're going to secure that airway, because that becomes very problematic. So that's how I'm trying to integrate that into our curriculum. And I'm also trying to integrate about conversation, communication with whoever's sitting at the bedside as their advocate. And then for postgraduate education, I have a CEU module that's with the American Association of Nurse Anesthesia. They have my talk and questions associated with it. So there is CEUs for practicing CRNAs right now, and then competency framework. So looking at the 8 competency domains for disability care. So with I think, with the 8 competencies, the one that kind of stands out to me is clinical care over the lifespan and during transitions. Because in the literature, there's a lot of information on dentistry, dental anesthesia, and children, or anesthesia and children. And somehow it kind of stops after that. Like, okay, what do you think is going to happen after they're done being a child? I mean, they're going to grow up and they're still going to need care. So I think there's a huge gap when it comes to adults with intellectual and developmental disability and anesthesia. There's a huge gap there. So again, I think these competencies highlight definitely a great framework of what we need to be working on. So specifically with challenging behavior, we might be misreading what's going on. So you have to look for, like, is there discomfort somewhere that they can't articulate? They have chest pain, toothache, abdominal pain, and they're demonstrating it through actions, but they can't articulate it. So we need to be a little bit better at being detectives and trying to rule out what the issue is and not just write it off like they're being problematic. And, patients with IDD, they have twice as many health problems. They have laundry list of comorbidities associated with them. And so, that goes hand in hand of the high-risk patient. So with communication barriers and them they don't really complain. They are known for not complaining. So they don't know to complain because maybe they don't know the significance. Like if they have chest pain, they don't know to speak up about it because they don't know the significance, because they haven't gotten care. They haven't gotten preoperative or preventative care. They don't have a regular doctor. So who's going to educate them to know to advocate for themselves? And that's a huge problem. And then with us specifically, putting someone to sleep with intellectual and developmental disability, and if they have a past history of trauma, physical trauma, sexual trauma, mental trauma, you name it. As I was putting that girl to sleep yesterday, she kept saying to me, remember, I shake. And I kept saying, right before she went to sleep, it was the one last thing that I leaned down to her and I said, I will remember. You go to sleep, I will remember. And I get teary-eyed thinking about it because, like, that's what she's worried about. She's worried that I'm not listening to her. And I was. But these patients wake up with emergence delirium, very combative wake up. They can injure themselves. They can injure others. They can fall off the operating room table. This is huge. This is a huge problem. So when us as anesthesia providers, we need to make sure that we're telling other, healthcare workers in the room, the surgeon, the circulator, the scrub nurse, scrub tech, that we need extra people in the room when we're waking this person up to kind of buffer this person so they don't injure themselves, so they don't fall off the OR table, so they don't injure other people. And so then we can calmly wake this patient up and they feel secure. And there is a lack of support, with this grouping of people because maybe they don't have the post-op instructions. They don't understand them. They're not being followed through. And there's no maybe follow-up or follow-through or case manager making sure that the person in the group home or their own home is actually making sure that these things get done for this patient if they can't do it for themselves. So how do we improve? So we have to look at the current challenges. So historically, we're bad. We don't listen or communicate, respect the views, patients with IDD. We need to put that out there and talk about it. It's the elephant in the room. We just need to acknowledge that. I think that's number one, And then absence of professional disability training, that's an issue, So we need to start putting that in, and that just needs to be second nature. And then we really don't have any planning. We don't have any guidance what to do when somebody has a behavioral disorder and that's associated with maybe some trauma. So, what we decide to do is just kind of, restrain them. And then now the patient's feeling more anxiety. So it's kind of backwards. So we need to look at some preoperative considerations. So assessing behavior in pre-op when they're fully clothed, when they have people around them that they trust. Bring in the patient maybe a day before, let them look around their surroundings, maybe meet some people in the OR or in the facility, have somebody as a liaison for that person. And one of the big things is confirmation of NPO status, nothing to eat or drink after midnight. This is a huge problem because these patients don't know maybe, or they don't understand the significance of aspiration and death associated with a full stomach for anesthesia. And if we don't, as the anesthesia providers, really talk to the correct people, who's taking care of this person, and finding out definitively they haven't eaten or drank anything, we're going to go into the OR with this patient with a full stomach. This person's going to aspirate and die and have a poor outcome. This is a huge problem. So starting the day before, whether we have to lock the food up or make 100% sure that this person doesn't have access to anything because they, again, may not understand the significance and problem. And then comfort and dignity. I think that we need to leave this patient fully clothed and then let them have control over the situation about, getting changed into their gown and getting ready for the procedure. And if we are assessing the patient, maybe the day before, or we bring them in the morning and leave them fully clothed when we assess them to make them feel comfortable. But we don't have to really, we have to make some special circumstances. And then with anesthesia management, like I said, we tend to overuse deep sedation or general anesthesia because we just don't know how to deal with them. So we're just going to put them to sleep. Just put them to sleep, don't have to deal with them. We have to, again, confirmation NPO status, because the problem is we oversedate somebody. That means we blunt their protective reflexes, coughing, swallowing, and they can't prevent like vomiting. So if they're going to vomit, they can't protect themselves. So we need to really confirm they haven't had anything to eat or drink. And then we need to think about, just like with my daughter, we have to modify our anesthetic plan and technique. So here's plan A, what we might do if we get into this situation. Here's plan B for this situation. So we have a multimodal plan and not just be like, okay, well, they're going to be a problem. Let's just get them sedated and asleep and get them to shut up and not do anything. And then we can move on with our day. And, these patients might need a little extra time. So either we put them on first thing in the morning and bring them in early, come in early and first thing in the morning and take that time, or we do them if they can towards the end of the schedule. So then they have all the time in the world. So we have to figure that out, what's best for that patient. Benzodiazepines, midazolam Versed is, antiemetic, and it helps relax, and it also creates amnesia, purposeful, and we tend to give that as a pre-medication. Believe me, when I have surgery, I want my Versed. I don't want to remember anything, but sometimes we overuse Versed in this circumstance. So maybe if we're going to use midazolam to help calm the patient down, try to think about how much we're giving this person. And, maybe if the person doesn't have this kind of, medication on board and they get disinhibited, maybe if we don't give it to them, maybe they'll be more cooperative. So it just depends. We have to look at our patients as a whole instead of just a blanket move, like everybody gets this. And then looking at things like ketamine, Precedex, we can give these in like micro dosing, and they help keep the respiratory rate intact, and they're kind of more of a dissociative, hypnotic, where the patient isn't all the way to sleep. So that, there's some advantages to looking at different medications, and you can use microdosing, layered effect, and not have this just like going to snow the person when it's very unnecessary. And then environment, patient comfort, when, pre-op area is very loud, not supposed to be, but it is. There's lots of things going on. And so maybe find a quiet room for this patient, help them. They're nervous too, right? I get nervous when I have surgery and I work there, so everybody gets nervous. If I get nervous, everybody gets nervous. So to them, there might be some overstimulation of what's going on, what's moving, too many people moving fast, touching, that kind of thing. So let's just slow it down, put them in a separate room, calm them down, let them take it all in, create that safe space. And maybe, like I had said, keep them last case of the day. Recovery, we need to alert our recovery room nurses and let them know maybe we need to bring the caregiver in to help with recovery, which would be fantastic. Keep them at the bedside, reorient the patient, see somebody that they recognize and know and feel comfortable with, and then work on that slow emergence. Like I said, these patients become very combative post anesthesia and emergence wake up period. And, you know, if there's different drugs that we can use, like microdosing, like I was saying, we have a smoother wake up. And then staff training, we need to alert hospital administrators, because this is part of, you know, maybe our annual training, you know, like we have health streams and annual training that come up, right? I think this would be fantastic if we could start integrating this in, you know, they talk about workplace violence and sexual harassment and things like that. This is something that I think that we need to start advocating with our hospital administrators about regular training for staff. And then also highlighting and the whole staff, especially in the OR, the surgical patients on the floor, that these patients are really the highest of highest risks for developing a post-op complication. So let's get ahead of it and not have to do reentry into the hospital. And then have communication improvements, whether it's visual aids, you know, you personally need to be better at listening yourself, surgical planning, pre-op and post-op planning. And then if there is a caregiver, you know, we need to, you know, maybe that caregiver is there for the day, for that shift or something like that. But that caregiver needs to be appointed throughout the entire perioperative period. And if somebody comes in to relieve that person, you know, that next person that comes in there has to be a report given. So then it's a continuity of care for our patients with IDD. So primary, I took the liberty of creating different anesthesia considerations. So I named them kind of as primary, secondary anesthesia considerations. So first, you know, there's anxiety. There's definitely an increased incidence of anxiety with patients with intellectual and developmental disability. There's also increased incidence of bipolar disease, and that can affect mood stability. Increased incidence of schizophrenia. So we need to understand if somebody has, like, they could have anxiety, bipolar, and schizophrenia and be just have an intellectual disability. Like, just because they have an intellectual disability doesn't mean they can't have other things layered on top of it. And I think that's where people are so ready to label something and then move on. But this could be very complex, and we need to appreciate that. Dementia, delirium is very prevalent, especially with patients with trisomy 21. And a third of those patients will develop Alzheimer's early on. And that's why I was saying too, with benzodiazepines, we might try to tailor that benzodiazepine, because if the patient already has some pre-existing dementia or something like that, you know, you're going to give them a benzodiazepine that makes them forget anyway. It's just going to amplify it. There's a lot of cardiac anomalies with the ventricular and atrial septal defects, and congenital heart conditions with patent foramen ovale, patent ductus arteriosus, which is a persistent fetal artery that affects circulation, and coarctation. So coarctation is narrowing of the aorta, which influences the systemic blood flow of the patient, which also influences, you know, anesthesia care. So we have to realize that there are very serious anesthesia considerations, and they're physiological. Now, other primary anesthesia considerations would be, I again took the liberty of putting them in sections, subsections. So it'd be communication, understanding what kind of patient medication regimen they're on, making sure that if they have, you know, who's signing the consent, that they understand to the best of their abilities, that they can understand what's happening. And then recognizing the importance of the caregiver, because there's caregiver burnout. We also have to acknowledge the caregiver, but also making sure that there's consistency with the caregiver. You know, because I've had patients where I'm pre-upping them, I'm talking to them, and then I'm, talk to the patient first. Then I ask the caregiver, and I don't know, I just came in today. I don't know. It's like, okay, great. So now we've got to call the home. So let's call the home. And I need to talk to somebody that really does know about this patient, because we can't go any further if I don't know the answers. Epilepsy, liver health is a problem. These patients are often on multiple medication that influence liver function, and we should be getting regular liver enzymes and liver function studies, tests, because we also want to know about therapeutic levels. We want to know, because our anesthetics, a lot of them are metabolized by the liver. And with that, these patients can go through a higher amount, they may have a higher tolerance because of the liver enzyme activity that's going on. So it tends to metabolize the anesthesia quicker, so you might need more. Seizure management, the girl I took care of yesterday, she has seizure disorder on top of, everything else, but it just kind of paints that picture of what she was misdiagnosed with. And so our patients that have seizure disorders, a lot of medications we need to avoid with somebody that has seizure disorder. And we also need to make sure that the medications they're on, they have the therapeutic level to control the seizure, because you don't want to have a seizure under anesthesia. They get stroke, not good. And we also want to make sure that everyone's aware post-op that this patient has a seizure disorder. So we talked about overstimulation, but there's also increased sensitivity in the ear with noise and vibration. There's poor oral care across the board. So this is very, very common. Unfortunately, I deal with it all the time with my daughter, but this also makes it a very challenging airway with poor dentition. So when you go ahead and we put our instrumentation in there to put the breathing tube in, we could knock a tooth out, it could go into the lung. This is a very big problem. Increased aspiration risk, not only because we're not 100% sure that this patient ate because they're sometimes non-compliant, but not purposefully, but with the increased physiological lack of development, or there might be fistula formation that communicates between the esophagus and the trachea, specifically with trisomy 21. So these patients aspirate all the time. So, we need to understand that, because not only does it lead to pneumonia, but it leads to death. And it's very, very sad when, I'm involved in a case that person with IDD and they aspirated after anesthesia and they died. But it's not my case. But I'm just saying, like, all it took was somebody to make one phone call. And that one phone call to someone that knew if that person ate or not. And if that one phone call was made, the case could have been delayed and the patient could be alive today. But you see, this is a very common thing where people are just disregarded, and it's very sad. We talked about heart disease, chronic kidney disease. Again, these patients are on multitude of medications, also eliminated by the kidney, which also our anesthetics are eliminated by kidney. We need to have a greater appreciation of what is their renal function, so then we're not giving, like, our different anesthetics, specifically like medications that relax the patient, meaning muscle relaxation, paralyze the patient. A lot of them are eliminated through the kidney, and they can have profound lasting effects, a long time metabolize off. So, these are things that we just need to avoid. If we can avoid them, then there's other medications that we can give that are metabolized differently. And then difficulty with intubation, not only because they have poor dentition, but there's a lot of different physical anomalies that with facial structure, that maybe the skin, like, you look at the person, they don't look so bad, but underneath their bone is malformed. So we need to be sending these patients for a CT scan ahead of time, so we can actually see what's going on before we just go in and try to intubate somebody. So this is why, like, we're rushing through these patients, and we really should be kind of pumping the brakes and looking at them a little bit more closely. Now, here's some secondary considerations. So if they don't normally, maybe the person doesn't have a true anxiety disorder, there can be an acute anxiety that develops when they're in a strange surrounding. I mean, I feel it when I go in the OR. It's like I have an acute anxiety. All of a sudden, I'm just like realizing, oh my God, this is real. You know, they feel the same way I feel. So, you know, that's a secondary anesthesia consideration. Obesity is very common, and that's a secondary, I would consider a secondary event that develops over time, maybe poor management, poor nutritional advice, or none at all. Untreated visual disorders, because the patient doesn't complain, they don't know that they need like glasses or help with reading or anything. So they just don't even, we don't talk about it. So we need to appreciate if the patient has a pre-existing visual disorder. If they have systemic disease, meaning diabetes or hypertension, and that's secondary to maybe the obesity. So if they don't have essential hypertension that they were born with, or diabetes type 1, the diabetes and hypertension develop with the obesity. So now we've got this triad of comorbidities on top of what we're trying to handle with patient with intellectual and developmental disability, and then sensory concerns. So we looked at anesthesia specific. So, you know, anesthesia consent, aspiration, airway assessment, airway management, ASA status, meaning that we assign a number. So it's the American Society of Anesthesiologists, and we denote a physical status classification to each patient, and it ranges from 1 to 6. So 1 is the least complex patient, up to 6 is the most. And so we give a number to each of our patients, and that denotes the complexity associated with our patient. So a lot of these patients, you know, would be a 3 because it's a chronic disorder. IV access is always a challenge, and it could be not because they don't have veins, but because the patient doesn't want us to touch them right away. Airway assessment, maybe they don't want us to, you know, assess their airway right away. You know, these are why we have to take time to get to know these patients, and that's why we have to bring them in early and have a calm atmosphere. Pulmonary oxygenation, because they do have physiological anomalies within the lung, especially with trisomal 21. So they may not exchange, have the exchange of O2, CO2, like maybe a normal population. So we have to take that in consideration. Pain management, maybe the patient's not going to complain at all, or we feel like they don't need pain management because they don't have pain. You know, it's incredulous to me to even think that. Positioning, now patients with developmental disability, they have range of motion limitation. So we have, you know, just because they're asleep doesn't mean we get to do whatever we want when they're asleep and move their limbs around. If their limbs are constrained, they only have certain range of motion. We have to honor that range of motion while they're asleep. And then the post-op recovery and management. So some conclusion and next steps. So there's a critical need, you know, for IDD training. It's really should be essential for all nurse anesthesiologists. There should be accreditation changes, and, you know, I'm part of the accrediting body for nurse anesthesia. And I'm noting in their new accreditation standards, they're talking about everyone and across the lifespan. They're being very inclusive. I'm very happy to see that they're being very inclusive to this population. And that's it. So thank you for your time.